Good afternoon and welcome to our webinar here at CMQCC on the journey to QBL, creating a culture of change on your L&D unit. We will give just a minute or two for people to get onto the call and then we will start. Good afternoon, everyone. Welcome to our webinar this afternoon. We are glad that you could join us. I want to welcome everyone and do a little bit of housekeeping. All of the attendees are muted upon joining. Continuing education contact hours are available for registered nurses through the California Board of Registered Nursing, and real-time attendance of 50 minutes at a minimum is required, and completion of a post-event evaluation to receive your contact hours. The slides and the webinar recording will be available in 2 to 3 days on the CMQCC website and on our YouTube channel. We would like to request that any questions be put into the Q&A box, and we will have time at the end of the webinar for questions. So I'd like to go ahead and do a brief introduction on our speakers this afternoon. Melissa Rosenstein is an MD and Associate Professor of MFM at the Department of OB/GYN at UCSF. She's the Medical Director for Quality and Patient Safety and Obstetrics, and she is also the Medical Director for the Maternal QI Academy at CMQCC. Jennifer Airhart is an RN and a clinical nurse at UCSF Health, and Marichele Punla is an MSN and RN and a perinatal nurse educator at Stanford. She's formerly the perinatal educator at UCSF. So with those introductions, I'm going to turn it over to Melissa. Go ahead, Melissa.
Hi, everybody. Thank you so much for joining. So I'm going to give a little bit of introduction. I'm so excited to be here with my colleagues, and we're going to basically tell a story. We're going to tell the story of implementing QBL at UCSF. And hopefully that will help you in your journey at your hospital. So the first is the what and the why. So what is QBL and why do we care? And then I'm going to hand it over to Jen, who's going to talk about getting ready and all the planning. And then Marichele's going to talk about rolling it out, implementation. And then I'm going to finish up with just some sustainability and implementation pearls. Next. So again, the learning objectives, we want to talk a little bit about what are the benefits of doing this, what seems like kind of a big deal to implement QBL in your unit if you haven't done it yet. We're going to talk about the importance of a robust planning period. We're going to review examples of how to successfully implement QBL based on our experience, and we'll be clear that this is one way to do it. There are many, we'll tell you ours. And then talk about like the strategies of really how to implement practice change and support that sustainability of a practice change, which is what we're all hoping for. Next. All right, so what is QBL? So this is, official definitions, the attempt to quantify the amount of blood anytime during the birthing process. So you can do QBL antepartum, you can do it during delivery, at the time of delivery, either a vaginal or a C-section, and in postpartum. And really, there's a lot of different ways that it can be done, but whatever it is, it's more than look and guess, right? So whatever estimating, which is look and guess, this is a little bit more. And so there's different ways of doing it. There's volumetric, where you measure the volume. We'll talk about, we used a little bit of that with calibrated drapes. There's gravimetric, which is weighing. We also did a lot of weighing of different things. There is a whole technology that's out there in terms of computers and photos and AI, and we did not use that. That is certainly a possible option if that is what your hospital wants to go on. Don't get caught up on the fact that we didn't do that. I think a lot of what we're going to talk about in terms of the implementation, the planning, and the sustainability is going to doesn't matter on how exactly you do it. And of course, what's important is ACOG makes this clear is it's not just the weighing or the measuring or the recording, it's the collecting and the reporting the cumulative blood loss. So sometimes the abbreviation has gone from like QBL to CBL, cumulative blood loss. We're just going to call it QBL, but we're assuming that not only are you doing the weighing and the measuring, but you are also keeping an eye on what's happening and continuing to go from there during the patient's journey on your unit, and if they leave your unit. Next. Okay, so why do we care? So we know from data from California, from reviewing all the maternal deaths in California over a period of time, that hemorrhage is the third leading cause of maternal death. And we know from reviewing those charts that almost 70% of those cases were thought in retrospective review to potentially have been prevented. And so the idea is if we're going to be able to respond to a hemorrhage and potentially prevent a death or a severe maternal morbidity, we need to be able to recognize what's going on. And we know that from studies where they, tested people, that visual estimation underestimates blood loss. And so there's that concern. Of course, other things you might care about are the fact that the Joint Commission Perinatal Standards cares about this. And when they rolled out their new standards in 2022, this is part of it. And there's really this move towards QBL being a global standard of how we talk to each other about blood loss, and that there's something more than just the surgeon looking and guessing. Next. So, and there's, people will often ask like, well, what's the data, right? And the truth is that there isn't data that QBL in and of itself makes a huge difference. But that makes sense, right? Because the point is that measuring the blood loss is not all you're going to do, right? You are going to be doing other parts of the hemorrhage bundle. And many of you have started with QBL as part of a hemorrhage bundle. We certainly did. And the idea is that this is one piece of that whole step. And we do have data from California that implementing a hemorrhage bundle does decrease morbidity. It does decrease blood transfusions and severe maternal morbidity. And honestly, one of the most exciting things about this project, it shows that it decreases the racial disparities in severe maternal morbidity due to hemorrhage, which we know exist. And figuring out a way to narrow that gap on inequities and disparities is something we're all trying to do on our units. And so as part of a hemorrhage bundle, QBL is really a foundation for how we talk about with blood loss and hemorrhage. It's really the foundation, can decrease disparities in your unit. Next. But you'll also hear us talk a little bit about the kind of the real why, is that it's just a great way for interdisciplinary communication, for nurses and midwives and doctors to just like come together and talk and have a two-way interprofessional communication. The process is led by the nurses, although we'll talk, it could be other folks other than nurses, anyone who's trained could do it. And what I really love about it is it turns blood loss into a conversation rather than a one-way declaration where the surgeon says, this is the blood loss, end of story. You have nurses doing the measurement. We'll talk about this more. It really brings the unit together. And we've found that that has benefits outside of hemorrhage. Next. All right, so this is the last slide before I turn it over, which is just to show the implementation framework that we used when we did this. And you'll see there's a whole phase one, which is this assessment. And we're going to stress how important this phase is when you're getting ready to do something. We're going to talk a lot about the assessment. Excuse me. And then there's the training and the implementation. And then there's the sustainment. And there's a lot of different implementation frameworks that are out there. This is from Team Steps, which means it's free. And so you can go to the AHRQ website and find this. Again, we're going to use this as a framework for what we did. And I think just being thoughtful and planning it out when using this just to remind you kind of where you're at can really help you make sustainable change. So with that, I'm going to hand it over to Jen.
Thank you. Okay, so I was tasked with organizing and rolling out QBL at the UCSF Birth Center. Something important to note is that we did try doing QBL a few years prior, and it was a massive failure. So I had to look at why was it a failure in the past. And the biggest things were that it was rolled out and there was no nursing admin support. So we were told, okay, do QBL, but there was really no one there to help. Also, there was no education given to OB and anesthesia. So there was no buy-in from them. Like, why should they care? It's not a thing, so it didn't work. So keeping that in mind, there were a number of people who rolled their eyes at me and were like, oh my gosh, we need to do QBL again. And so I needed to make it better and make it work this time. So I also observed the current state. So who is doing what in a delivery? What will need to change? Who will need to be involved? Again, as Melissa said, it's not just the surgeon or midwife or whoever saying, okay, EBL is this number. It is a cohesive group process. I needed to look at what was our process for EBL and what were we actually doing for postpartum hemorrhages. Also, a part of this getting ready experience was consulting with frontline experts. So at one point prior to my involvement, Melissa and our CNS and I think a couple other people actually went down to UCLA to see how they did their QBL process, and they learned a lot from that experience. The other thing that I did was that I asked nurses who at this time we had a lot of new hires, and luckily a lot of them had done QBL at their previous hospitals, so they came with a lot of experience and lessons learned. So that was super helpful. Next slide, please. Okay, so I just needed to get started and go in to observe C-sections and figure out how we're going to do QBL. So I went in and just observed again who was doing what the process was, and I figured out some of the details needed to do QBL. One of the things was to get accurate wet and dry weights of items that we used, looking at when to start measuring. So I know in the past, one of our missteps was figuring out what to do with the amniotic fluid. So we decided that the best practice would be after delivery of the baby, the gutters in the drape get suctioned of all the amniotic fluid, and I'll go into this step by step shortly. But this is like all the minutia that I was looking at during each delivery in trying to figure out QBL. I looked at how we can best weigh the laps. So we have the lap counter bags. I have pictures in a minute. Just basically, how are we doing this efficiently and so that it's not feeling like 10,000 extra steps for nursing, because that's always an issue. Next slide. So after going to all of these deliveries and figuring out the process, I just wrote it down and tried to make it as clear as possible and as simple as possible, because we all know that no one likes multiple steps and confusion. Just makes life harder, and it's a setup for failure. So writing it down, making it clear. Preparing the tools that we would need for doing QBL. So one of those things was in our electronic charting, doing a QBL calculator, which I'll talk about that in a minute, putting a paper form in every chart. So upon admission, your chart is made, you have all the papers in there. One of those papers was this step-by-step process of doing QBL. So that picture was there, everyone had it, they could easily reference it. Having scales in every room. In our previous attempt at QBL, the scales in our labor rooms were stolen. So, we were a little apprehensive to actually put scales in every room again, but we did. And so far, knock on wood, it's been good. And also really important is the use of a graduated under buttock drape. And I'll go through that in a minute as well. Also super important was setting the stage and being transparent that change is coming. So again, not a whole lot of us like change. And knowing that we had totally failed at QBL in the past, it was really important to me that people knew that, okay, we're doing QBL, it's going to be better, it's going to work. People would see me at C-sections and know, oh, Jen's here, we're going to do QBL, and it just became a thing. Also of note, when we were developing this QBL process, initially it was going to be just for C-sections. Then it was like, well, maybe we should do it for vaginal deliveries that were turning into postpartum hemorrhages. In order, again, to make it just super clear, we decided for every delivery, no matter how it's done, we are doing QBL. So just every delivery, it's not guessing, oh, are we doing it now? Are we not? Every delivery doing QBL. Also recruiting super users for the rollout. So this was asking our management if we could have dedicated people who would not be put into staffing, who would be there on shift in order to help the nurses attempt to do QBL in real time, but having those dedicated bodies there to help. Next slide. Okay, so who is doing QBL? Mostly QBL is nurse driven, doing all the weights and measurements and everything. But as we know, staffing is an issue. Always tight with staffing, right? You're running around doing 10 million other things. So anyone who is trained can do QBL. So some of our scrub techs are really great. And if they are not scrubbed in, then they will come in and help in the OR, and they will do all the weighing and measuring and everything. And it's amazing and super helpful. Nurses remind the team at the beginning of the case that we will be doing QBL. So this was a bit of a challenge at first, because I would be there and I would say, okay, we're doing QBL. Sometimes there was eye rolling and grumbling, but now everyone does it, like we're just used to it. So just having that presence there of someone saying, we are doing QBL, end of story, that's it. Nurses are doing the calculations along the way, and we also are giving the QBL updates during surgery. And I have a really nice picture of this in a minute. Nursing gives the final QBL at the end of the case. So again, this is not a provider, OB or anesthesia just saying, oh, okay, our EBL is da-da-da. No, this is like actual numbers. We've done the math. This is our final QBL. Next slide. So again, this needs to be done at all deliveries. It just gets everyone in the habit. All vaginal deliveries, all C-sections, everything QBL. The MDs needed to get used to counting laps and needed to get used to trying not to drop them into the bag. And if they were dropped into the bag, then they had to fish them out. At the end of every birth, we should be doing a timeout, and we should be making sure that QBL is documented. And this last point I think is super important, is that it doesn't need to be perfect. Like if you find a towel on the floor after you've done all of your QBL and that has blood on it, don't worry about that. Like it doesn't need to be perfect. We do the best that we can. We try to capture accurate blood loss, but if we miss one little thing, it's okay. Next slide. So the way that we educated everyone and rolled this out is that we did our annual skills validation. So this is our yearly training that we do, and it's a 4-hour session, and it ranges in everything from the boring stuff like how to do your POCT for urine dipsticks to whatever's the latest and greatest in labor and delivery. So this year it happened to be QBL. So it was 5 separate days. We had 190 nurses at that time. So everyone had to sign up for this. If they didn't sign up, then we assigned them. They had to attend one of the 4-hour sessions. In that 4-hour session, they received 1 hour of lecture and hands-on of how to do QBL. Rolling out QBL happened after everyone had completed this annual review. So everyone had some sort of familiarity with it. They had gotten the lecture, they had had hands-on, so it wasn't going to be a surprise. At the time that we rolled this out, we were also rolling out a few other new kind of big changes for us. One was use of whiteboards in the LDRs, and also use of surge account to count in and out our laps in the LDR. We also reviewed our postpartum hemorrhage carts, postpartum hemorrhage medications, and also reviewing massive transfusion protocol and emergency release blood. Next slide. Okay, so here's the fun stuff, the nitty gritty of actually how to do QBL. So this is the under buttocks drape that we were using at the time. And as you can see, it's graduated, it has the measurements there. So after the delivery of the baby, before the placenta, you and or the provider will be looking in the bag and seeing how much fluid is in there. Next slide. After the placenta delivers, after the repair is done, after all the potential bleeding has happened, you're going to look at the amount of fluid in the bag again. Sorry, for that last slide, we are going to look at the number and note it on our whiteboard. So you have your beginning drape number. And then this is your final drape number. Next slide. You're also going to weigh all of your bloody laps, anything else that gets bloody. Next slide. So on the right side of the screen is the handy dandy little handmade, hand-drawn algorithm that I came up with. So the first number that we looked at after the baby was born is your baby delivery fluid. And you subtract that from the final fluid level, and whatever that number is considered your drape QBL. And then as far as your laps, towels, blankets, whatever, you get your dry weights and you subtract that from your wet weight. And that is your lap QBL. To get your total QBL, you add your drape QBL, lap QBL, and any other blood, and that is your final QBL. I think Marichele made it look nice and pretty, and that is what she came up with on the left side, much better than my hand drawing, but okay, next slide. So for a C-section, we are going to deliver the baby. At this point, the gutters of the drape will get suctioned out. In the beginning, we had to remind the providers to do this, but now everyone's pretty good about it. We do delayed cord clamping for most of our deliveries, so it can be done then. Next slide. So after the gutters of the drape have been suctioned out, you're going to go over to your suction machine and push the reset volume button. So any blood after this time is considered your QBL. So we're getting rid of that amniotic fluid. Next slide. You're going to separate the bloody and non-bloody laps for weighing. So usually, you know, they'll start off with like 2 dry laps. I just put those to the side. Everything gets scanned in and scanned out as usual. But all of your bloody laps, you're going to put in your lap counter bag. Take that whole bag, put it on we just use a baby scale, and weigh that, and then subtract your dry weights. Next slide. Sorry. So for a C-section, again, a review of the workflow. At the timeout, remind the team that QBL will be completed, so everyone has that awareness. Remind the team to suction the drape of all the amniotic fluid after delivery of the baby. So after that happens, then you're going to go over to your suction machine and zero the suction machine. You're going to weigh your laps, and again, whatever else gets bloody. Before they irrigate, you're going to look at the amount in the suction and note that number, and that is your suction QBL. At the end of the case, when they do that final fundal massage, anything that is expressed from there, we are going to weigh that. And then under the patient, if there's a significant amount of blood under them, then we're going to weigh that as well. Next slide. I went to work yesterday morning and was immediately sent into the OR to finish a case. And I saw this on the whiteboard, and really nothing could make me happier. I think that this is a really good example of QBL. So it looks like they had probably zeroed the suction 3 different times. There were 3 lap bags that were weighed, and then the white part, the last line, I think, is the huge white chucks that's under the patient. So that patient had a QBL of 2295. Next slide. The way that we document it in our Epic is we have a little QBL tab, and there's 2 options. One is, so on the left side, we can just write in total QBL and put our number in there. The other option that we have is using a calculator where all of the dry weights of items were put in there. I don't think many people use that anymore. And something that we've run into with that is due to supply chain issues. All of our, not all, but a good number of our supplies are various weights now, which I'll talk about that in a minute. But just know that there is an option to do a calculator. Most people don't. Most people just do the calculations on the whiteboard and then enter that number in the documentation. Next slide. Okay, so we did a soft rollout, and this was our super users who, most of which had prior experience with doing QBL, and they really wanted to be able to help out and just kind of familiarize our staff with, this is how we do it. These are kind of the expected numbers, helping with any snafus that happened. We did this 2 weeks before the expected go live. Next slide. So I am going to hand it over to Marichele at this point, because at this point, I had to have surprise emergency back surgery, so I wasn't able to work. So I called my lovely office mate, Marichele, from my hospital bed and said, hey, can you please help with rolling out QBL? And she did an amazing job, and she is going to talk about it right now.
Good afternoon, everybody. So now that y'all have the background of how this important work was started, I'll go ahead and discuss how we went live with this process. And that includes how we kept our nurses and our providers engaged, which ultimately led to the success of QBL at UCSF. And then I'll talk about how we kept up the momentum on the unit and how that eventually supported that culture shift. Super users were a critical piece in the go live process. They are the eyes, ears, and advocates for the frontline staff. So we wanted to empower the super users because they were the ones that were ultimately leading this work. And learning from experiences of using super users, it's so important to really set those expectations for your super users so that they understand what is being asked of them. We were able to have, with the support of our leadership, 24-hour support between the nurses and the providers during our go live, and that was 24-hour coverage for about the first 2 weeks. We also set up meetings that not only included the attendance of our nurses, but also the attendance of our providers, so that everyone understood what was expected of them. Not only were super users the hands-on support on the unit so that every single nurse felt supported when they were attempting to perform QBL, but they were also expected to collect data, to collect feedback from the staff regarding the QBL, and were responsible for reporting that information out during our huddles. And it was really important to do that because we can sort of look at different themes that were happening, right? And then we could continue to work on the improvement of our workflows and processes. And then it helped with that sort of empowerment of the nurses and the providers in having that voice in making that change. Next slide. This is an example of how we scheduled our super users on the units. We wanted to, again, ensure that there was 24/7 support. And again, these nurses, these super users were out of the count, so they were not, unless it was something urgent, we were not to pull them back into staffing so that there was support for our nurses. This schedule was left on the charge nurse's clipboard for visibility. And I also just want to, continue to highlight the support from leadership that helped maintain this support for the first 2 weeks. They ended up staffing up for the first 2 weeks so that super users would stay out of the count. And this was also important so that we can maintain engagement of the super users, right? Because they felt like, oh, for this shift, I'm the super user, and they were excited to do it. And it wasn't them having to come in already anticipating being pulled into staffing. Next slide. Audits are really important during this process whenever you go live with anything. And when it came to audits, real-time audits were so important. And again, the super users were an integral part in this, in the audit portion of this. They, again, were the ones that provided us the data that needed to address any barriers and also continue, the improvement work to make QBL perfect for our organization. We captured almost all deliveries and audited for completion and proper documentation of it. The audits were done manually at this point, just so that we can look into every piece of the chart, because as we know, sometimes when you roll live with something, people will chart in different areas of the charting system. And we would find that, QBL was documented in the provider note, but then in the nursing documentation, it was missing. So then, we wanted to ensure that every delivery was getting credit for QBL being performed. And because of this, because of the visibility, because staff knew that they were being audited, it really helped with accountability for staff, right? So because it was known that it was being done, it really helped enforce that practice. It also, with that platform of staff being able to give feedback on ways to make it better, it really empowered them as well, right? Because they felt like they were being heard. This is also an important and crucial time to give feedback to staff in real time. So a great example of when we had to give feedback about QBL was there was a delivery that QBL wasn't completed because there was a hemorrhage, right? Well, when someone's hemorrhaging, this is really like a crucial time that we're performing QBL. So it was an opportunity to have that discussion with that nurse or provider that, hey, like this is actually a really good time to perform QBL because we want the most accurate amount of blood loss for our patients. Next slide. So this was definitely a level 4 education, and we needed a way to easily track that staff were meeting the criteria of getting that knowledge, skill, and assessment completed. So we came up with sort of a checklist, and we gave out stickers, and the sticker was the QBL star there on the screen. So anytime the staff completed QBL on a vaginal and a C-section delivery, we would give them a star to put on their badge. And that was a visual cue for us to know that they have been checked off and they know how to perform QBL. We also, we had a list of our staff, 190 staff on a clipboard, which was our master sheet so that we knew which staff we still needed to get checked off. And really an opportunity and a funny story about this is we actually lost that list at some point. So lesson learned, if you do that, you should actually keep a digital backup as well. And then to keep the energy, momentum, and the progress we made to keep that going, we also had support and got pens that said QBL Superstar because, right, who doesn't love a good pen? So that was a really nice extra thing that we gave to our staff. We also did raffle tickets for staff. So every time you completed a QBL, you would get a raffle ticket. We'd put it in the box. And every week we would do a raffle and you'd win a Starbucks gift card or whatever we had for that week for gifts. We also wanted to celebrate, right, because we were meeting our goals. So we did provide staff a cupcake party, and that was just a small gesture for us to show our appreciation to the staff. Next slide. So with the work of the super users, again, how I said they were so important in identifying, opportunities. There were some opportunities that we had identified. One of them being double charting of QBL. Through the audits, we found that for C-sections, QBL was being double charted. So anesthesia would chart, right, their QBL, and then nurses would go in and also chart their QBL in our documentation. So that when we went back and audited, we saw that the QBL was being doubled. So as soon as we recognized this, we worked quickly. We partnered with anesthesia to sort of try to create a solution. It definitely wasn't an easy fix, but we did find a workaround in this that made it work for us until we could actually fix the problem. And the solution, in collaboration with anesthesia was really important. And that just really highlights our collaboration between both disciplines. Also in the birth center, our staff functioned in all roles. So they worked in L&D, antepartum, postpartum. And it was just, when we got to the postpartum side of it, we focused so much on the delivery side in the beginning. So a couple of questions came up, right? If your patient was transferred to postpartum and maybe 2 or 3 hours later, they started hemorrhage again. The question was, where are we charting that, right? And then when we're charting it, if we're charting it on the flow sheet, is that being calculated into the cumulative amount? So we were able to look into that, and we did confirm that it does accumulate on the actual QBL final in the patient's chart. There was also, like Jen said, there is a calculator. A lot of work was spent on creating the calculator for Epic, because we really had to think about all the different things that blood would, end up on. And with the audits, we realized that nurses really didn't use it. Like, I would say maybe about 5% of the nurses used the calculator for QBL, while most were just comfortable doing it manually. Next slide. So we began to make this shift, and it was more part of our culture. We sort of continued on that momentum, and like how we integrated it into our workflow. We do post-delivery timeouts for every delivery. So with that, this is a picture of how our post-delivery timeouts look and what we discuss and the questions that we ask. So as you can see there, the first question that's asked is, was QBL completed, and what was the QBL, right? And this timeout is done in a multidisciplinary approach. So you have providers, you have nurses there. So you can talk about, if QBL wasn't completed, or if it was completed, why was it so high? Or, did we treat it? Did we do everything? And this just helps the dialogue communication between the providers when we're taking care of our patients. Next slide. So this here is success, right? We were very fortunate to have a really successful rollout this time. And we were also able to present this at our UCSF Health Improvement Symposium. And I think for myself, when you're rolling out something, data is really important, and it speaks volume, right? And when you present your data in a graph like this, it's really encouraging, and you want to share this with your staff, right? You want them to know that they are doing a good job and we are making improvements, right? So as you can see here from our soft go live, we were barely performing QBL in vaginal deliveries and C-sections. One, because we didn't have the support that we had in place, right? The first 2 weeks, that was crucial. But then as you can see, we moved into week 5 and beyond. And it doesn't show here, but we kept this audit going, and we kept it going for a few months. And I don't think we ever dropped below, I would say 85, 90%. But as you can see in week 5 and beyond, we were just exceeding our benchmark of QBL on 80% of deliveries. So definitely our super users, our leadership staff, and our frontline staff were a huge influence on this, on the success of the implementation of our QBL. Next slide. So what next? So when we implemented QBL, it was really part of a bigger goal, right? We were really trying to follow the CMQCC hemorrhage bundle, and we made it clear to our staff that QBL was just a small part of what we were trying to implement on our unit. So our next step was, after we had QBL standardized, we wanted to move on to further develop our postpartum hemorrhage protocol, and included stage-based management of postpartum hemorrhage. So when we introduced QBL, we already conversed that this was, a small part of a bigger change into our workflows in how we manage our patients who have hemorrhages. So we moved on to formalize an active management of third stage, where we updated order sets in all of our care areas to include PRN medications to treat postpartum hemorrhage. This really enabled the nurses to work autonomously and call out interventions needed to treat QBL timely, because we know that providers sometimes might be tunnel vision. So it was always good to have nurses sort of in the background calling things out when needed. We also revised our postpartum hemorrhage risk assessment, which was also updated and included in our policy. This created more awareness of the higher risk patients that they were caring for, and being more prepared in the event of a postpartum hemorrhage. SBAR, a lot of focus and work was also done with this, right? Practicing what was needed so that communication was clear and the urgency was evident, especially when someone was hemorrhaging. And SBAR was not only focused on the nursing staff, but it was also focused on our providers as well. So it was a team effort. Our IV iron protocols were also updated to match best practices. So, as you can see, our work didn't stop with just the implementation of QBL. We continued our work for the overall improvement in the response to hemorrhage. Next slide. And now I'm going to hand it back over to Melissa to talk about sustainability and implementation pearls.
Thank you. I love reliving it. It was such an exciting time. And so we heard now about kind of like why, and then what we did, how we got ready, and you can hear that that was a big part of it, and then what we actually did. And so I'm just going to kind of review a little bit before we take questions, kind of what we learned in terms of rolling it out to make it work. And so the last slide just shows really like the first step to sustainability is the implementation, right? So you just want to make sure that when you do it right. And again, it takes a lot of time for planning. But once you put in all that effort and particularly, like we've said many times, as super users, that sets the stage. You do a lot of the work in the beginning and then it rides by itself. And right now we really pay very little attention to QBL because it just happens. And so one of the ways that we worked on this in the planning phase, so this is a tool for planning, is something called the 6 sources of influence. And this is something that I have found really useful. It's useful for all QI projects, but it's a way to really like make sure that you are touching everybody and you're going to help make that behavior change and help it stick. So next slide. So it's this basically the idea that you're trying to support both the motivation of your staff and the ability of the people that you're asking to change their behavior. You want to support their motivation and ability, and you want to support it in all different levels, right? There's the personal level of who we are as individuals, what's important to us, our motivation, what we are able to do. There's the social, labor and delivery particularly is a very social unit. We work together. We've talked a lot about that. And then there's the structural of like the bosses, right? And what's around you. And so this is how we filled out this graph, right? So we talked about kind of making sure people were personally motivated. We told stories about unrecognized QBL, particularly remember that person who was bleeding in postpartum, but nobody really knew because we were just saying that she was bleeding, but then all of a sudden it ended up being like a huge hemorrhage. Imagine if we were able to quantify that, how that would have made a difference, right? And then we talked about how we were able to train all of the individuals in terms of the annual skills review. The providers got trained. Again, they didn't get as much training because they didn't have as much to do, but we just went over it in our provider meetings often with all that refresher. So now we have individuals who are able to do things and who are motivated to do it. Definitely the fact that it's the standard of care elsewhere, that was true when we did it a few years ago, is for sure true now. So I think you could definitely use that if that's still something you're struggling with. I think the social piece of it was a really big help. So again, for the motivation, the super users were able to say very clearly, we've done this before. It's not that big of a deal. You can do it. And then the super users were also really important in doing that hands-on, right? So when you're in the middle of a delivery and you're like, oh my God, what am I supposed to do? I can't remember what I learned in my skills lesson. You had somebody there who could offer help. And again, we were able to have 24-hour coverage out of staffing. We know that that might not be a possibility for everybody. So even if that person is not out of staffing, depending on the acuity of your unit, having somebody identified as the super user, even if they're doing other things, and maybe then you can do some, when there's a delivery or when there's a hemorrhage, then that super user can come over and try to help and maybe do some rearranging if you can't have dedicated time. And then we talked about the structural things that we did to keep people motivated. We talked about the stickers and the pens and the emails and the dashboard, as well as the actual structural changes we needed to make on the unit to make sure we had the ability, right? So we had to develop the checklist, and maybe we didn't need the Apex checklist. Maybe nobody used it, but people felt very strongly about it in the beginning that they wanted that option. And we allowed people to do that, or write it on paper, or do it on the whiteboard, made sure we had the scales. We had to get the drapes. You had to get everything ready so that the structures were in place to be able to do what we needed to do. Next slide. So the second lesson, the first lesson is implement, go all out. The second is share questions and wisdom. So again, we were able to travel to learn from another hospital. Again, that might not be possible for everybody. So you don't have to go very far. I think this counts, right? The CMQCC has the share website where people are able to share, we'll share our documents, and you can hopefully, if others have had experience, that you'll be able to find others. So where you can hear that it has been done. Again, I think staff, you must have some staff who came from someplace else where they did it, really try to elevate that and tell stories. And so that was helpful. And then again, we were able to then become the experts. Here we are giving a lecture, right? When we struggled so much, and we were able to invite other hospitals to come visit us. And again, I think really elevating our frontline staff and elevating the folks who worked on the front line, it really gives a sense of accomplishment and pride. Next. We didn't talk about this that much in the beginning, but we did incorporate team training as part of this rollout. So the reason we found out about the team steps implementation plan that we highlighted is that we did team steps. Now, again, we recognize that that's not available to everyone. I think if you can advocate for that at your hospital, it will give you this protected time to plan, and it gives you this change framework. And then it also, like Marichele said, it tells you how to use SBAR for all your communications, which is our new favorite thing to do. Anytime we communicate about any quality improvement, we always use SBAR to remind people that that's how we're supposed to talk to each other. So again, and even again, if you can't get like full on team training, sometimes that like is just too much. Although I would say if the hospital is like trying to get something QBL done and has been unsuccessful, then this could be the thing. It's like, well, what we really need is we need to be able to communicate better, which is what QBL will help you do. But if you communicate better, you'll do better at QBL. So it comes together. But even if you can't get dedicated team training time, and of course it doesn't have to be team steps, just using that kind of language and using that kind of framework, because like we said, the team step stuff is all available free of charge. And so that's just a little way to get some of that team communication, shared mental model, right? There's nothing like QBL to give you a shared mental model for discussing with your team members. Next. And then again, the last piece is, again, just dealing with the worries, right? Like nobody likes change and people are grouchy. So the things that we found to really help with that are the soft go live was a huge help. And you could hear it was like actually two, right? When Jen was going into the OR, she wasn't even like, everybody else did what they were doing and she would just quietly do her thing, or she would take over and do it. And so people could see that this was happening. So nobody felt like this was coming out of nowhere. And that's when she learned like, oh, wait, we got to do it this way instead of that, or like, oh, that's not working. And then the soft go live was, again, an opportunity for people who knew what they were doing, who had done it elsewhere, to give it a try so that other people could be like, oh, what's happening over there? Oh, we're doing this. Oh, okay. So they learned about it and we were able to troubleshoot. So by the time we rolled it out, we were tight. Again, we would say, don't sweat the pink stuff, right? So people, again, very detail oriented people who work on our unit, and I'm sure on yours as well. I need to weigh this. What about this? Like we said, it's not perfect. Don't worry. If it's pink, don't worry about it. Just if it's red, we don't care if it's pink. And, it's not really QBL. It's not really quantitative. We don't necessarily need the number to be, it could be a 0 at the end. Like it doesn't need to be totally perfect. We would joke around. I brought a jar of jelly beans to, and it's like, you're just trying to guess what it is. It's not really, it's more than guessing, right? Anything is more than guessing what's in the jar of jelly beans, but it doesn't have to be the exact number of jelly beans in order to win. And I think another piece that was really important in terms of particularly getting provider buy-in is that there's no penalty for hemorrhage, right? So back when we did EBL, right, the number of people who had a 950, right, blood loss at their time of their cesarean, there were a lot of people like that, right? Because you didn't really want to call it a hemorrhage, so you said it was like 9 to 75, right? So once we got rid of the penalty, it didn't matter if the QBL was 110 or 1005 or 1200. Again, when we rolled it out as part of the stage-based hemorrhage protocol, which was provided by CMQCC, you'll notice that it's the amount of bleeding, but also whether or not there's continued blood loss. So QBL is not the only thing that makes a decision about what happens to the patient, about what the follow-up is, about where she goes in the unit, or whether or not she gets a CBC. So we just really took away, there was no penalty. You don't need to feel bad. We didn't follow providers and why did you have a hemorrhage? It was just one piece of data. And then again, this comes from our colleague, Dr. LeGroux, who says the thermometer analogy. People will be like, you don't need QBL. I can tell when I have a hemorrhage, right? And he'll say, okay, just because you can tell when your kid has a fever by putting your hand on their forehead doesn't mean that a thermometer is not also a useful tool, right? It's not the only thing that tells you that a patient has a fever, but we have not abandoned the thermometer as a tool. And so it's the same idea. Yes, many times you can get a sense of what's going on just by looking, but this gives you a little bit more basis. It gets rid of a little bit more of the arguing. She's having a hemorrhage. No, she isn't. It's like, this is the information that we have from the math and can be helpful in more situations than just looking and guessing. Next slide. So that's it. We found this picture of our QBL enthusiasm. If it's red, weigh it. And we hope that you were able to hear about how the the implementation of QBL really led to that interdisciplinary communication and collaboration. In order to achieve that culture change, we had to do all of those things, really listening to who you're at, listening to what the concerns are. Sometimes you just want to be like, don't be grouchy, just be, but if you can listen to the grouchy people, sometimes, you learn something important and help to make it better for the next time. Lots of time spent planning, lots of time spent adjusting and making it better, and then lots of celebrations. And really keeping it sustainable. And I think what we've learned and what we hope you learn also is that while it's really important to do QBL, once you do this, you feel like you can do anything, right? That you can really use the same model to do other improvements on labor and delivery, which we know there are a ton of. So thank you so much. I think that's the end.
Thank you so much, Melissa, for that great presentation. We're going to move to Q&A, but very quickly, I just want to plug that CMQCC is doing lightning rounds monthly. So if you are a CMQCC member, we do have QBL tools in the MDC, and they'll be doing a lightning round next month. So if you're interested in that and you are a member, you can go ahead and register for that. And I did drop it in the chat a couple of times. All right, so questions. We have a lot of questions. So I love it because everyone's so excited about QBL, and it really does prove how timely that this presentation is, and that QBL is a struggle for most people. So the first question is, we know that dry weights fluctuate frequently due to changes in manufacturers and materials. Supply chain issues have exacerbated this problem. How frequently do you recommend recalculation of dry weights to ensure accuracy?
So yes, supply chain issues, not fun for QBL. I mean, we are a pretty good team of like scrub and resource nurses where I work at UC, that we are pretty focused on new products. So if there is a new product, then we usually try to communicate that with the team. Again, we don't want QBL to be like a stressful thing. If you are concerned about a new product, then take the 10 seconds to weigh this looks like a new lap. Take the 10 seconds to weigh it, get your dry weight, and then do your QBL.
Thank you. There is sometimes confusion about QBL when the placenta has not been delivered and there is already amniotic fluid, but there is possibly a large blood loss prior to the placental delivery. How best can you determine what to count and what not to prior to placental delivery?
I'll say again, like it's just a communication. I think this is like back and forth. This is where the communication. So if you're at a vaginal birth and there's a big gush of fluid when the baby comes out, and then all of a sudden you notice, oh wait, the placenta's still in, but she's bleeding. Again, that's something everybody in the room should know. So, hey, the placenta's still intact, but she's bleeding. Let's start our QBL. And then again, you look up at the bag and maybe there's some blood in there because you already, she's already been bleeding a little bit. So you either say exactly what it is or you estimate a little bit, right? Again, it's not perfect. I think that also, again, with this idea of the new lap sponges, if you feel it and it looks different, but like feels more or less the same, again, the difference is probably not going to be that much. But the idea again is to say she's bleeding. It's, the placenta's not out. We're going to call it now. This is our baseline, even if the placenta hasn't come out yet.
Do you complete the post-delivery timeout at the bedside? And if so, is the patient involved?
Yes, it's the best. This is, I think, again, one of the greatest things that came out of this whole process is this bedside post-delivery timeout. We do it in front of the patient. We can share this example because I think it's so great. And you may have noticed that it says at the end, like, are there any questions? Does the patient have any questions? And it's just an incredible opportunity for the patient to be able to talk to the care team before everybody disappears. So yes, we're big fans of that.
Did you write a specific policy about QBL?
So yes, in doing the postpartum hemorrhage redo, which Marichele worked on, the QBL process is part of that protocol.
Do you have any suggestions on obtaining suction QBL in facilities that don't have the Neptune?
I'm not familiar with other, I mean, actually, no, let me take that back. I think since we've rolled out QBL, we did get new suction machines, but every suction machine should have the capability to, I think it's like reset or 0 or something, but there should be a button on there that you can like clear what's on the screen already and start over. You don't need to like change canisters or anything like that. Does that help?
I think if there are some organizations that don't have any type of suction, they just use the regular suction with canisters. I think for that, you just definitely have to have, you just need to pay very close attention to what's in those canisters and, you know, jot down like the amounts that you're seeing and sort of in your mind when, you know, when you've already deducted that amniotic fluid.
Again, I think it's the communication, right? Like part of what we do is to say, and again, we used to put just another piece about like the announcing that we were going to do QBL. It was actually on our timeout board, right? Like there's a checklist of things you have to say, and we wrote QBL announcement so that like it was, you didn't have to remember, it was reminding you whoever was doing the QBL whoever was doing the timeout would announce it. And then that's part of the announcement. It's like, okay, baby's out, we're suctioning the gutters. That the gutters are suction. That's what the providers have to say. And then the nurse, again, will either hit the button, but if you don't have a button, then you look at the canister, you figure out what it says, you can draw on it, you know, with a marker, or you just write on the whiteboard the same way you would with a vaginal birth.
When calculating QBL in the OR, how do you account for wet laps? In the model, the dry weights were subtracted. There are variations on how wet the laps are. Do you have any suggestions?
Oh boy, this was a hot topic. So we use scrub nurses and scrub techs. A lot of our scrub techs have come from other facilities where they do QBL and they know their wet weight, so their lap that they've squeezed out to their liking. Most of them it's 50 grams. Okay, so then there's people like me where I scrub once every 6 months. So I will hand over a lap at the beginning of the case and then one at the end of the case, and we'll do an average if we're really that worried about it. Again, trying not to make it too stressful, but the more, because when I was going through this, just weighing over and over and over people's wet laps, like generally they're 50 to 60. We were going to go with just one set number and then decided to go with people's personal numbers. So you can do it either way. I don't know, Melissa, do you want to add more to that?
Again, I think it was this idea of like, it might not be exact. Maybe it's 55, maybe it's 50. It's sort of like getting an average again. And I think, right, our team didn't want to be locked into somebody else's wet weight. Everybody wanted to have their own. We said, fine. If your people don't want to worry about their own and you want to say it's 50, you know, you can get an average from most of your staff, that's also fine. But yeah, every time we say dry weight, we meant the wet laps. That counts as part of the dry weight.
Great clarification. We recently did a massive postpartum simulation and found that nurses constantly weighing took a lot of time. Is it best to just weigh and measure at certain times, or stop measuring or measure less frequently, especially in a small rural site with limited staff?
I would say weigh less frequently. If you're in the middle of a postpartum hemorrhage, yes, you want to be weighing, but you don't want someone constantly, you know, okay, I'm going to weigh these 5 laps at a time, this 5 laps. Like, you can let it accumulate over a period of time and then weigh and then communicate and update your team. Yes, it does take a lot of time to weigh and do the math and all that. So I don't think that it's necessary that it needs to be like a continuous thing, but periodically checking the weights and adding it up and updating the team and writing it down.
And I think what I want to add to that is, right, for everything, your patient comes first, right? QBL can be done. And I think once you've built that culture of QBL, somebody will come in the room and just say, who's doing QBL? If not, I'll do it, right? So you have to build that culture where it's just completed. So hopefully even managers will come in, right? Folks that like are maybe not clinical all the time. If you're short staffed, they'll come in and help.
And again, what blew our mind the first time we figured this out was this idea that you would weigh 10 laps at a time. Like when we first saw that, we were like, that makes so much more sense, right? So take the 10 laps, you put them in the bag, and then you weigh that whole thing together and you know what the weight of the bag is. And it just saves like so much time. So I think nobody should be weighing individual laps, because if you have less than 10, it's probably not that much of a hemorrhage anyway. And like you can do it afterwards. And if you have 10, every 10 is a good time to weigh. So I think that's the other reminder. And again, it's just this conversation. If you don't have enough people in the room to do the QBL, like, do you have enough people in the room to do the other things that you need to do, right? So if you need more people in the room, granted it's a small hospital and you might not have that many people, but if it's really a hemorrhage, it sounds like you're going to need everybody there. And QBL is only one of the tasks that extra staff is going to be there for.
I also just wanted to clarify one thing. All of our dry weights, we have on a laminated sheet. So, you know, small blue chucks, large blue chucks, small placenta bucket, all of those dry weights are on laminated sheets that should be in every OR and every labor room, so that we can easily just look at them. There's the dry weight, and then do our math. I don't think I said that earlier, so I just want to clarify.
And then I would just add to the rural piece, this is Krista Sakowski, one of the clinical leads for CMQCC, that if you are in a rural hospital, you might want to consider an OB-RRT, and like set up that mechanism that you have for calling for extra help. Maybe it's off the unit. So, you know, for our rural, UCSF, we've got a lot of nurses there, but for a rural hospital, if you only have 3 nurses on the floor and you need more hands, you might want to consider that you would activate that rapid response team sooner rather than later. Did your MDs write an EBL in their delivery summary prior to starting this? And if so, how did you get them to change their documentation to state QBL and not EBL? And have you had any issues with double charting by anesthesia team at C-section?
So yes, we did have a lot of EBL still. They would chart an EBL and the nurse would document it as QBL, but you know, it was just a culture and something that had to change. And I did describe that in the beginning. Yes, there was double charting because anesthesia, they have their own separate system that they chart. So when we caught that, we obviously had to work in partnership with anesthesia, and anesthesia would document it for the meantime, but they would have to write a note that it was QBL. And then once it flowed into the chart, we just kind of knew in comparison with the provider charting that it was QBL. So there was a little bit of that, but I think it's now been fixed, Melissa. They've updated. Okay.
Yeah. And again, I think it was this idea of the docs, you know, they could still write EBL. We told them to stop, but if they still would, the QBL would go in and then we would just count that. So generally the docs would just write the EBL in their note, and then the QBL goes into like a flow sheet. And so when we're talking, like, that's what we talk about. And so again, you know, we try to agree, but say, listen, you don't need to write your EBL. Don't worry about that. We got it. And we got it where through Epic, where it will flow into the delivery note. And so that makes, you know, it does mean that it has to be timely. But then again, that's part of that post-delivery timeout, is that you shouldn't leave the room until you know what the QBL is.
Mm-hmm. We are encouraged to use the Epic calculator to capture the detail of the blood loss. It is thought that a total number without detailed calculations would be a potential liability. Do you have any thoughts on that concern? Okay, nothing from legal.
Yeah, it's still better than guessing, right? Your alternative is guessing. So I feel like it's still better than EBL.
Did you find the rates of hemorrhage changed after implementing QBL on the unit?
Yes, and other places will see this, that they go up. For sure they go up. I mean, definitely you also have cases where you would have a vaginal birth and it was like 150 and people would be like, what? Or you have a C-section that's 350 and people are like, that can't possibly be right, because I was taught that it would never be less than 600. But it's just getting used to it. And again, because you're not necessarily doing anything different, if it's 1200, you just notice it. And then again, I think the issues are, looking at your other things. And it's really just raising awareness. And there may be, a bit of an over, you are sending more people to the ICU and you are transfusing more people. And again, it's hard to know where the right place is, but as long as your unit is being open about discussing that, of like, we're seeing more of this. And then you can stop and think, are we overreacting? Like, do we need to look at vital signs more often? Do we need to have more of a conversation with anesthesia? It just opens up the conversation.
We've been struggling with QBL for 2 years. Our goal is 100% of deliveries. Is this a realistic goal?
Yes and no, right? You want to aim for something that's attainable. And once you've gotten to that attainable, then I think you can increase your goal. But I think it's not fair to say that off the bat, we're going to be 100% compliant, because even for us, as huge as as UCSF was, we did not have 100% compliance. So I think set your goal to something that's attainable, right? Because you're probably going from 0, and to go to 100 from that is pretty, that's a lofty goal.
Are there specified times in the OR for the QBL updates?
Not really. Usually, so one thing is we write everything down on the whiteboard. So there's that visual cue there. So like in that slide, that picture that I showed from yesterday, you could see the suction amount, bag number 1, bag number 2. So all of that is written down, and everyone knows now to look there for what the QBL is.
Where do you keep the weight of dry laps for easy reference?
We have them on a laminated paper, and they're on a ring holder in all of the ORs and in every labor room, and also on our postpartum hemorrhage cards.
How do you manage disagreements about QBL volumes?
So again, I think it's this idea of like, what's going to change, right? Like, it doesn't matter really. Like if the surgeon's like, no, it wasn't possibly that much, it was much less than that. Like, okay, fine. It doesn't matter. Like if the patient is stable and she's fine, it doesn't matter. So I think that's part of it. It's just like taking away anything. And if the doctor says, I'm worried, I think it was more bleeding than that, the doctor wants to get a CBC, like, or, that there's always going to be a clinical discussion. This is just one part of the clinical management, is not the only part.
Once you started QBL, how long was it before providers stopped eye rolling and got on board?
I think it was, we like I said, we made a big deal about this. We were like, it's coming, countdown, it's 2 weeks. And then we were everywhere. Like it was a 2-week big blowout rollout, and you just like could not avoid it. And so there was no time, like, and by the end of 2 weeks, it was done. Like, that's what we did.
But I think too, to add to that, Melissa, it was really important to have that provider champion. So we had a champion from the OB side, and we had a champion from the anesthesia side. So basically, right, like from the top down, like this is the expectation. So that was really important in getting everybody on board, because I know that in other organizations, not everybody's on board, but when you have someone up there saying, this is what we're doing, like this is the standard, this is the expectation, then people will slowly, right? People don't like change, but they slowly get into it. And then it becomes the normal thing to do.
And people can still roll their eyes and be grouchy, like that's fine, but it doesn't matter because we still do it. So I think that's the other piece, is like, it makes it more unpleasant. But in the beginning, I think people were like, when, Jen got the most of it when she was going into the OR by herself, trying to get it started of like, this is what we're doing. But then, that's why you give it plenty of time, and then it happens and people can still roll their eyes, but the nurses know what they're doing and they just get it done and write it down. It doesn't really matter.
Yeah, and I think at the end of the day, reminding them that this is improving patient outcome. It's not because we just want to do it because we want to do it. It's really because of the patients, right?
All right, that was our last question.
Can I
from-
just say one more thing I
Oh.
just see about postpartum? I just see there's a lot of questions about postpartum. And I think in postpartum, we also, it was again, like if it's red, right? So if it's like, we defer to the nurse. Like if the nurse looks at the normal lochia and is like, this is normal lochia, you don't need to weigh it. If the nurse says, this is a hemorrhage, I am worried, I want the doctor to come. Again, this is one of the things I think we found was the best. If the nurse thinks that that's a hemorrhage, she weighs it. And then when she does her S-bar, when he does it, you can say, I have a QBL of 400 under my patient in postpartum. Please come and evaluate now, rather than my patient is bleeding. Can you come and evaluate, right? Like the QBL offers that extra piece. And so it is an option for when you think that there's a hemorrhage, but if it's normal bleeding, you don't need to weigh everything. That's where we're like, no, the nurse gets to decide really what needs to be weighed and what doesn't, because we trust their clinical judgment.
Thank you, everyone. Thank you to our speakers, and thank you to Krista for moderating those questions. We will, as we said, have the slides and everything available in a few days on the CMQCC website and on our YouTube channel. Thanks for joining us today, and have a great afternoon. Bye, everyone.